Hello and welcome everyone to the Macular Degeneration Association virtual program. Today's topic is going to be geographic atrophy, so we hope you're ready to hear about that. First, a few housekeeping items. We want to remind you that we will have more of these programs upcoming, so we would like you to visit our website at macularhope.org, where you can find a full list of programs that have yet to come on, as well as completed programs that we have recorded on our site. You can peruse the many subjects and find something that interests you. We would also like to thank our wonderful sponsors, Regeneron, Apellis, Sun Pharma, AbbVie, and MacuHealth, as well as Notel Vision for their support of these programs. We'd also like to thank you for attending. We are a 501c3 nonprofit. We are supported primarily from individual donations. So if you find this information relative to you and you would like to make a donation to help us bring more information to people in the community, we would appreciate that. It is a fully tax-exempt item according to law. And so we would appreciate a donation at the aforementioned macularhealth.org. Today, we have a wonderful speaker for you, Dr. Leo Sims. Dr. Sims earned his OD from the Pennsylvania College of Optometry and completed his residency at the Eye Institute of the Pennsylvania College of Optometry. He currently holds an appointment as Professor Emeritus of Optometry and Vision Science at UAB. Dr. Sims has authored numerous articles and contributed to many books. Dr. Sims is a fellow of the AAO and a founding member of the Optometric Glaucoma Society, where he has served as secretary and on the executive committee. He is also a founding fellow of the Optometric Retina Society. In 2015, he received the Educator of the Year award from the Alabama Optometric Association. He has also been recognized with the Dean's Distinguished Service Award in 2016. Dr. Sims has been recognized as one of the 50 most influential eye care in 2015. We are now going to hear from Dr. Sims on geographic atrophy. Sorry, that's a very difficult word. So, Dr. Sims, we look forward to hearing from you.
Thank you very much, Dusty. It's my pleasure to be here and share some information on geographic atrophy, which is a topic that has really been a bit of an enigma throughout my professional career until very recently. And that's what I find most significant. I also like to, on my title slide, have some sort of a quote, and today's is "Discovery favors the prepared mind," from Louis Pasteur many years ago. So let's talk about the landscape of geographic atrophy. And what I'm showing you here is the greener grass of my neighbor on the other side of the hedges here in Florida. And what I want to use this analogy for is the fact that this is a very nice uniform lawn. And that's what we see in the retina as a normal situation. So let's turn our attention to retinal anatomy here and just kind of put a few things in perspective to get the lay of the land here. The eyeball itself is about the size and shape of a ping pong ball, and the lining is the retina. One of the things that is a landmark is the optic disc, or the so-called blind spot. If you've ever taken a visual field test, you know about blind spot. And that's about as big as a pencil eraser. So when we're talking about size, we can appreciate that the retinal blood vessels, for example, are about as thin as hairs. But our focus today is going to be on the fovea and the macula. And we're going to talk about macular degeneration and look at this nice, pristine landscape of a normal retina and how departures from normal result in geographic atrophy and other forms of age-related macular degeneration. Some of the things that we know about AMD are that it's a leading cause of vision loss in the United States, and any of you who are card-carrying Medicare beneficiaries are aware of that. The middle name, macula, as I mentioned, is really the center of vision. and not only our focus today, but what provides us with sharp vision and allows us to do things like read what is on the screen today, see what we look through on our windshield, appreciate everyday objects, see our ball, our golf ball, as we hit it down the fairway. And what we have learned about age-related macular degeneration over the decades is that there are two types that are often put in separate buckets, but there is sometimes an overlap between them, and we should understand that they can potentially coexist together. The main feature about age-related macular degeneration in either of its forms is that it's a multifactorial disease, meaning that there are a number of causes, and we'll talk about some of those and how we might want to mitigate their effects, but it is a chronic disorder. We're all familiar with how important vision is in terms of our daily activities, but a number of years ago, Dr. Gary Brown from the University of Pittsburgh decided to try and quantitate it. And what he wanted to do was determine what the relationship between vision and quality of life was. So he developed a questionnaire, which is called the Visual Function 14. It's a 14 question metric that assesses quality of life in terms of daily activities. And his results were quite significant. And what he found in terms of results is that the average person with 20/40 vision, so relatively slight impairment, kind of the threshold for driving in every state in the union, but the person with that level of vision in the better seeing eye was willing to trade 2 of every remaining years of life, 10 years of life, for perfect vision. However, much more significantly, the average person with severely impaired vision, which folks with age-related macular degeneration might experience in the better eye, was willing to trade approximately half of those remaining 10 years of life in return for perfect vision. So vision, very, very important. We're all aware of that as practitioners, and as well as patients or those of you who are viewing today recognize the significance of vision, whether it's a limitation, for example, on your driver's license or other daily activities. Vision is a very, very important sense. What we also know about age-related macular degeneration is that it is a significant public health problem, both in terms of numbers as well as dollars. And we'll explore the dollars here in just a second. But if we look at a couple of different things here on this bar graph, and we look at millions of people here on the y-axis, so we're looking at going up to 10, 15, 20, 25 million, we can see that Alzheimer's disease, which gets a considerable amount of recognition and play in the press, is about half as prevalent, or less than half as prevalent, as age-related macular degeneration. But age-related macular degeneration is about half as prevalent as all cancers. So kind of putting this into perspective in terms of other chronic diseases that may affect especially patients in older age groups. If we take a look at numbers and the economic burden, the total loss in gross domestic product is about $41 billion annually. So that's quite significant. And you can see that that includes direct as well as indirect cost among these 3 columns here. But if we direct our attention just to the dry or geographic atrophy portion of age-related macular degeneration, you can see that there are a number of tentacles here where cost is involved in terms of limitations to quality of life and income. So very, very significant there, not only in terms of public health, but economic burden. Age-related macular degeneration in terms of prevalence is greater than diabetic retinopathy, as well as open-angle glaucoma. And if there are any of you listening with either of these conditions, you recognize that they are more significant in patients as we get older. But you can see that age-related macular degeneration really kind of overshadows each of these, and in fact is more prevalent than the combination of those. If my fifth grade math is in fact correct here, which I am now reviewing with my rising granddaughter, who just will turn 11 in about 2 weeks. If we look at age-related macular degeneration in terms of progression, the cutoff for beginning screening or the beginning of statistics, for example, with the National Institutes of Health, is typically 50 years of age. You may be familiar with the age-related eye disease study, and in order to be included in that or to qualify for inclusion, you had to be over the age of 50. But what I want to draw your attention to, first of all, is the y-axis here, and we're looking at the number of cases per year in thousands as we go up here. So we're looking at 100,000 or a million right there. And then this solid line, and I'll ask you to focus just on that. This is just the confidence interval here, the dashed lines. But this shows the exponential increase in advanced age-related macular degeneration once we get to about the age of 75. And we can see that the prevalence just takes off once we get past about the age of 80 or so. And while that represents a small group of the population, it's really very significant because what we know is that people are living longer today. So the likelihood of developing advanced age-related macular degeneration increases significantly with age. And what we want to consider is, okay, what are means of managing age-related macular degeneration so it doesn't get to the advanced stage? What treatments are available when it's first discovered? And probably most importantly, how can we identify patients who would be at risk for developing and suffering the effects of progression of advanced age-related macular degeneration? We can look at it another way. And one of the things that we know about age-related macular degeneration in general, and what I suggested earlier, was the fact that it's a multifactorial disease or disorder. So let's look first of all at the larger slice, if you will, of the pie here, and recognize that there are genetic influences and you can't run away from your genes. So we have to factor that in terms of a significant risk factor for developing age-related macular degeneration to the extent of about 70% of risk. However, that's the non-modifiable side. What about the modifiable side? Number one is age. And again, we're all getting older at the same rate, too fast. So nothing we that. But there are some other risk factors that might be modifiable. And I've emphasized smoking here as something very, very significant. And I get on my soapbox about this all the time. It was the cause of my father's death. He was a lifelong smoker. To his credit, he discouraged his firstborn son. That would be me. But there are some other things, and we'll talk about these in perspective toward the end, that might be useful in minimizing the risk of developing age-related macular degeneration and suffering the effects of progression. So let's turn our attention to some of the early indicators of age-related macular degeneration, because that's the reason that I'm showing you my very handsome son-in-law here with his several-month-old son there. And having just turned 40 back in December, Brian has had to deal with his baldness for quite some time. And he has embraced it, he has accepted it, but the question becomes, when did Brian lose that first hair? When in the retina does the first sign of age-related macular degeneration show up? And we have very good imaging techniques that will allow us to image the outer retina and the retinal pigment epithelium And we'll talk about the significance of that and what that might look like on some tests that you may have had administered to you if you're at risk for age-related macular degeneration or a patient, and how that relates to finding the very earliest changes in age-related macular degeneration, which also kind of ties into what some of the potential therapies might be for that. One of the significant things about detecting age-related macular degeneration early is this statistic. And every time I see this, I'm just overwhelmed. I'm floored. Over 3/4 of age-related macular degeneration patients have irreversible vision loss by the time that they're first seen for an evaluation. So that to me is quite significant. And again, if we can roll back the clock and take a look at something that might be an early indicator, maybe we're going to be able to reduce this particular number here. So one of the ways to do that is regular eye examinations. And some of my former colleagues at the University of Alabama in Birmingham, some good friends are listed here as authors, were collecting patients and enrolling patients in an age-related macular degeneration study. And they had a great deal of data. And they decided to go back and they said, we've got all this information. What can we mine from it that might be able to tell us, to give us an indication of what early age-related macular degeneration looks like, what's the prevalence of it, how well is it diagnosed, what's the best means of diagnosing it, and so forth. And what I've highlighted here is the fact that about 1/4 of patients had age-related macular degeneration despite no diagnosis in the record. And to me, that's just shocking. And, reading between the lines and talking to some of my friends here, they were astonished as well. And you might be able to see some of the physical changes that are listed here. And you might be familiar with a term called drusen. And these are little lipid deposits that show up on color photography. We'll take a look at some examples a little bit later. But these can be very, very evident and should be identified on color fundus photography, which is kind of a baseline, a standard for following patients with age-related macular degeneration or those at risk. And this study was so significant that it was one of the top 5 stories in ophthalmology in 2017. So pretty significant there, taking a look at the early changes in age-related macular degeneration. So one side of the equation is what we as clinicians might identify in terms of early age-related macular degeneration. But as patients, we might want to become aware of symptoms. And one of the things that is very, very significant is really nothing too significant except for something like reduced dark adaptation or poor vision in low light. So think about how that might impact on or as a result of age, and a patient thinking, oh, well, this is just because I'm getting older. Okay, I can't run with the big dogs anymore, and it's just an effect of aging. Or, my neighbor has cataracts and maybe it's due to cataract. But someone who has difficulty adapting from a bright to a dim environment might be someone who is at risk for age-related macular degeneration. And that particular symptom can be quantified and has been shown as a biomarker in an instrument that was actually developed at UAB by Dr. Greg Jackson and commercialized as the ADAPT DX. It's a test that you may have taken in your eye care provider's office. So losing details in straight ahead vision. And one of the things that I'm always reminded about is a patient whom I saw whose first symptom was he came to see me. His wife was a patient of mine. And he came to see me because he said, Leo, he said, when I hit my golf ball off the tee, I can't see where it lands in the fairway. I can't always see that. He was in his early 50s. He had gone through a little bit of rehab in terms of a fitness program. He quit smoking, he changed his diet, he lost weight, et cetera, et cetera. He got off his diabetic medications. And we kind of joked around, oh, Bill, you gotta quit hitting the ball so far and blah, blah, blah. Well, over several decades, and I saw him over the course of about 35 years, he developed such severe geographic atrophy that he first lost his ability to drive. His wife had to drive him. He would walk down the hall with a hand on both walls so that he could see where he was going. And it was it was so sad because there was no treatment at the time. We have better things today, and we will get into that. So the clinical diagnoses, as I mentioned, might include dark adaptation testing. We mentioned that, as well as a dilated exam. And then we'll talk about our management options. And we talked a little bit about some of those lifestyle modifications that might be in play. But we now have intraocular injections that might be useful in patients specifically with dry AMD, as has been applied to the wet form or the neovascular form of age-related macular degeneration over about the last 20 years or so. So we've mentioned that there are two types, and the dry form is actually the more common. So it's always been surprising to me that with that being the more common, it probably represents over 3/4 of age-related macular degeneration, that there had never been more of a focus on treatments for dry age-related macular degeneration, where there was such an emphasis on the wet form. But if you have late dry AMD in one eye, there's probably little that can be done, but there may be some things that are available for slowing the progression and maintaining vision in the remaining eye, especially in the earlier stages. Now, if you're listening and you have been diagnosed with neovascular AMD, you're probably familiar with the fact that injections are available, and they were really the first treatment that actually improved vision in patients with wet AMD. And that was such a breakthrough. That was such a billboard, a headline item, that it was great news. And now we know that those treatments improve vision and they can stabilize vision, and that effect can last perhaps as long as about 7 years. So there's very, very good treatment for that. We don't know the long-term effects of these new injections for dry AMD quite yet. So let's talk about what your eye care provider may have shared with you in terms of staging age-related macular degeneration. And I have in parentheses there specification, because I always like to make the distinction, especially with my interns and residents, about the distinction between specification and performance. And I can tell you as a patient, oh, you have stage 2 age-related macular degeneration. And that's probably meaningless to you as a patient because you're worried about how you're seeing your golf ball off the tee down the fairway, how your night driving performance is, how close you have to be or how much light you need to see to read, how much magnification you need. And that's performance. And that's really a separate item from specification. So from the age-related eye disease study, and that's what this acronym is, age-related eye disease study, we're coming with that term drusen again. And again, if you're an AMD patient, you might be familiar with it. So we're looking at two things. We're looking at two changes in the eye, the presence of drusen, their size, as well as the presence or absence of pigmentary abnormalities. So we can think of it this way. If you have drusen and pigmentary abnormalities, you get a point for each. You have two eyes, so the maximum score is going to be 8, 4 points, 2 in each two eyes. 2 times 4 is 8. So a score of 8 is really quite significant. Most eye care providers are not going to be sharing that particular number with you, but it does give us an index as to the likelihood and the trajectory of progression for age-related macular degeneration. Now, we've talked about the two types or forms of age-related macular degeneration. And as I mentioned, we used to separate them into two different buckets. But what we've learned is that they can coexist in the same eye. And one of the theories decades ago was that everyone started with dry macular degeneration and progressed to wet. And we know that that's now not the case. But we do know that there are different progression rates for neovascular, which is here, okay? And you can see that there's a pretty wide range of progression. But after the diagnosis of early or intermediate AMD, a smaller proportion will progress to geographic atrophy. But you can see that these each represent about 50% of cases of advanced age-related macular degeneration. So these are the folks who are going to be receiving the highest level of treatment in terms of injections into the eye and very frequent follow-up, sometimes as frequently as once a month for the first few months and then maybe quarterly. And then now with some of the newer treatments, extensions of 6 to 12 months. One of the primary investigators in the age-related eye disease study is Emily Chu, and she has talked about prophylaxis for age-related macular degeneration. And she talks about the opportunity to study primary prevention. And we're going to talk about that. But as we saw in the previous slide, there are probably two different pathways, which may depend on genetic makeup, which may depend on environmental factors to a smaller extent. But if we could figure out which pathway any particular patient is going to take, where a patient might end up with advanced age-related macular degeneration, then we might be able to have a better handle on primary prevention. So one of the keystone ways of staging and evaluating age-related macular degeneration is using optical coherence tomography. You saw that phrase when I showed you my very handsome son-in-law. And it's a cross-section of the inside of the eye, and there are several different stages here. And you may be familiar with these scans, which are taken in your eye care provider's office. And what I want to focus on is advanced geographic atrophy here, where if you look at the area below the center cross sections here, you can see that they appear very clear in these first three, but there's a lot of light that is getting through the retina, which implies that atrophic process, allowing the instrument to see deeper into the retina. So a barrier there, and that retinal pigment epithelium has now become contaminated and destroyed and has resulted in this particular pattern. So if your eye care provider shares these images with you or uses them to describe what stage of age-related macular degeneration applies to you, it's something that might be of significance and something that has been shared with you. So specifically, how do we monitor geographic atrophy, since that's the main focus of our topic here today? Well, if we go back to our landscape and my neighbor's lush lawn begins to develop some atrophic areas, if you will, it's not going to be that nice uniform pattern that we saw early. It might be some disruption here in terms of loss or deterioration of the grass here. And we have a disruption of that uniform pattern. So if you think back to the schematic that I showed you with the retinal vasculature and focusing on the fovea, it was all very uniform. It didn't have this rocky, bubbly appearance here that we're seeing in this particular patient with geographic atrophy. And these are three different pictures over the course of 6 years. And you can see that the areas here change a little bit as we go through the pattern, but centrally things still look pretty uniform. And that's because this patient had what's called foveal sparing or center sparing geographic atrophy and maintained, despite the significant disruption in the clinical picture, 20/25 visual acuity. So this happens to be the better seeing eye, relatively good visual acuity here. Fellow eye is a different story, even though there's a somewhat similar clinical picture here. We've got this disruption that looks kind of rocky or bubbly here, and we see more of those areas as we go to year 2 from baseline. And then finally, some reorganization, as we as clinicians would call it here, that seem to center on the very center of vision there, the center of the macula or the fovea. And unfortunately, this eye suffered vision loss to the extent of 20/200. So the disruption here is quite central in the grass there and quite significant in terms of visual performance. So we can look with color fundus photography. We can look at OCT. And another means that is not universally employed by eye care providers is something called fundus autofluorescence, or FAF. And again, if these results have been shared with you by your eye care provider, and you can see baseline here at presentation, just look at the area that looks like it's deteriorated or a different color here, and how that has grown over the course of just 1 year. So this is a reminder that geographic atrophy can grow very, very rapidly. And a couple of significant statistics here is that the median time to develop central, so that previous patients' 20/200 vision over the course of 6 years, may be compressed in certain patients to affect the central vision and reduce visual performance quite significantly, and over the course of 7 years involve both eyes. So the early detection of age-related macular degeneration is going to be critical to our being able to correct problems and being able to modify things that might impair visual performance to the extent of central vision loss in both eyes. We can look at another example here. And again, this just emphasizes the fact that we've got this normal sandwich of retinal layers here, but you can see that that is absent here and admits more light. So if we think of those areas in the color fundus photograph, those rocky areas, as showing deeper areas of the retina, it's reflected here in the cross section, again, that your eye care provider may be doing on a regular basis if you're at risk or have any sort of age-related macular degeneration. And just a close-up here of that geographic atrophy patient looking at the fellow eye. One more example here, and this is a 70s white female whom I saw as a patient for many years. And this is in the era before we had any sort of treatments once patients had established geographic atrophy. But again, we can see these large areas. The smaller areas are drusen. The larger, lighter colored areas represent those holes in the lawn, that those areas of geographic atrophy, but a relatively spared central area, which doesn't show up that well here, but here is about the center of the macula, looks somewhat undisturbed or spared, and visual performance 20/40 over the course of 4 years. So a fortunate situation here in the absence of any of the now contemporary interventions that are available. But in the last couple of years, we've been able to now identify markers that are going to be telltale for trajectory here. And none of this is going to be on the test, but if we relate that to what's going on with this patient, we can see that centrally things look relatively undisturbed, but disorganization elsewhere around the center of vision. So a few things that are indicators for we as clinicians to give an indication of potential trajectory and reasons for intervention. We talked about the trajectory of geographic atrophy in general, and this is just another study to remind us that vision loss from geographic atrophy can be relatively rapid, and this has been quantified in the IRIS registry, which is a nationwide study of eye diseases. A couple other facts and figures here. We saw this top one from that graph in the beginning, that about 1.5 million people. And while that might be a small percentage of the overall population, about a third of those patients have advanced age-related macular degeneration, and some 20% of them are legally blind. We talked about age as a significant risk factor. So let's talk about some things that are potential contemporary treatments for geographic atrophy. One of our sponsors, Apellis here, was really the first to come up with an FDA-approved injection for dry age-related macular degeneration. And some very smart folks discovered that it was the complement system, and we're talking molecular level here, that it was the complement system that was compromised in age-related macular degeneration. And then they went back and began looking at molecules that would interrupt that process or stop that process. So their product, Sofovre, you might have seen a television commercial for it, is very, very useful in minimizing the progression to advanced age-related macular degeneration. A competitor, Izervay, has also been approved. We're looking at just about the first year anniversary of that. But again, it's a molecule that is designed to interrupt the complement cascade that results in the deterioration at the level of the retinal pigment epithelium. So very, very useful here. AbbVie is another one of our sponsors here, and brimonidine is a name that you might recognize if you're a glaucoma patient. It's a drop that is used to reduce intraocular pressure, and this may have some application as a topical drop rather than an intravitreal injection for age-related macular degeneration. And in terms of utility for long-term use, the intravitreal insert can last potentially up to a year. What about photobiomodulation? Why am I showing you my very attractive wife here with a red eye mask on her face? Well, what we know is that light therapy can be beneficial for certain dermatological conditions. It has applications in eczema, for example, if you're a patient there. And someone very smart said, well, okay, what if we apply this through the eyelids for dry age-related macular degeneration? There was a small study in Sweden, about 100 patients, and they found that there was about a 10-letter gain, which means 2 lines of visual acuity. So that's really quite significant. It's received the CE mark in the European Union, and the instrument that is going to be commercially available pending FDA clearance here probably before the end of the year is going to look like this. It's the Valida device from Lumithera. Just last night, and you can see I didn't get to bed too early, but just last night, my Medscape feed had this headline: Phototherapy, How Light is Helping Patients Heal in New Ways. And they talked about some of the dermatological applications, but they also highlighted the utility of wavelength therapy for age-related macular degeneration. dry age-related macular degeneration specifically. So something new on the horizon that kind of skirts the necessity for any sort of an intravitreal injection. If any of you are patients with diabetes and are taking metformin, you may have some protective effect there. Some studies have shown that there is a reduction of almost 50% in the risk of developing geographic atrophy in patients who are taking metformin. So maybe kind of a tangential benefit to having diabetes. Another molecule that has potential and has been now approved in the European Union, but is pending for a couple of other disorders, is lamipretide. And you're not going to be asked to spell this on the test, but it's something that may have utility for us in age-related macular degeneration and its benefit to mitochondrial substantiation. So in the last few minutes here, let's turn our attention to prevention, because we've talked about risks for age-related macular degeneration, specifically dry geographic atrophy, some of the new treatments that might be available for that, the means that we use to find the earliest stages of it. But if you are at risk, or if you have been diagnosed with age-related macular degeneration, specifically the dry form, or even application to the wet form, what can we do about it? Well, we talked about genetics as being the kind of non-modifiable side of the equation, but what about lifestyle modifications? I mentioned smoking. I can't emphasize that too much, but there are some things that we might be able to do in terms of dietary modifications, some things that we might be able to do in terms of lifestyle modifications, and then some things that might be indicators of early changes that might be subclinical and don't show up on color fundus photography, fundus autofluorescence, optical coherence tomography. So visual performance can be a very good indicator of some of the early changes in age-related macular degeneration. And of course, we can't neglect the genetic side of the equation. So just as a headline here, some practical age-related macular degeneration strategies here: smoking cessation, diet, and exercise. We're going to talk a little bit about nutritional supplementation, and then comorbidities, other systemic diseases that might be present. And finally, retinal light protection. Being a Floridian, I never go outside without my sunglasses on. Very, very important there. So just to emphasize the importance of smoking, current smokers have an enormously increased risk of age-related macular degeneration, specifically the late form, that catastrophic decrease in vision performance. But most AMD patients were not advised to stop smoking. So let that be a lesson to us, that it's something that may be overlooked in the examination. And about half of smokers didn't know that smoking can contribute to blindness. Excuse me. So if you're a smoker, quit smoking. My cough is an allergic response. I'm sorry, today is not a good day. What about physical activity? 150 minutes of physical activity a week. When I first heard this statistic, I was actually in a meeting with Dr. Gerson many years ago, our medical director. And he said, Leo, he says, break it down. He said, that's a half an hour, five times a week. And I thought, okay, that makes good sense. And since then, we've seen things like sitting is the new smoking. So activity is going to be very important to minimize some of the progressive aspects or nature of age-related macular degeneration. What about dietary influences? Well, this is nothing new. Hippocrates, who is probably best known for his first do no harm, the Hippocratic Oath, had another one. and that is let food be thy medicine and medicine be thy food. And it turns out that he also was one who prescribed light therapy for his patients. So light therapy, dietary modifications, these are nothing new. These are measures that are age old, have been tested, tried and true, and things that are quite significant and useful for our management of age-related macular degeneration. What about specifics? The MEDI here is a reference to the Mediterranean diet. And while this was a retrospective study, it was demonstrated that following a Mediterranean diet, these are just a couple of studies that were conducted in Europe, reduced the risk of advanced age-related macular degeneration. So some things we can do, and I realize this is a tough battleship to turn, but nutrient-rich foods like fruits, vegetables, legumes, and fish might be very, very useful for us there. 3 healthy behaviors reduce the risk significantly of age-related macular degeneration: healthy diet, physical activity, not smoking. So the literature is quite specific on the benefits of a good diet and physical exercise. And the age-related eye disease study has, over the past 2 decades, taken a look at the benefits of nutritional supplements and dietary components here. And you can take a look at what some of the components of the eyes that were recruited or included in the AREDS is. But what I want to draw your attention to is for geographic atrophy, all of these blue bars to the left are protective. All of the red bars to the right are detrimental. So we can take a look at what's detrimental, because that's a smaller group: fat, cholesterol, saturated fats, monosaturated fats, fatty acid, oleic, linoleic acid, alpha, et cetera, et cetera. And we all know that a low-fat diet is going to be beneficial, but we can also see that antioxidant vitamins, the carotenoids are very, very useful as some minerals. And one thing that I want to point out, because I've had so many patients say to me, look, doc, you want me to eat more fish, you want me to eat more vegetables, you want me to quit smoking, do I have to quit drinking? Well, let's look at the bottom line here: alcohol. And it turns out that alcohol is protective, okay, to a small extent, and that is not an endorsement to recommend drinking or alcoholic consumption as protective against geographic atrophy, but all things in moderation. So a glass of wine here or there, a beer once or twice, is probably not going to be harmful. So what are some sources of those fats? You can see them here. Because this is recorded, you can take a look and see what specifics there are here and use this as a reference for yourself, and then minimize the intake of some of these particular sources of oleic acid that are natural. And you look at some of these and say, well, gee whiz, avocados are supposed to be good for you. Eating olives, part of the Mediterranean diet. What about pasta, eggs, nuts, and so forth? Well, maybe just minimizing those intakes will have a beneficial effect. And most recently, and this is a report that will appear in ophthalmology again, part of the data mining from the age-related eye disease study demonstrated that the AREDS formula and the AREDS2 formula in non-central geographic atrophy, so those that form of geographic atrophy that is outside the center of the macula, you folks with good vision diagnosed with dry AMD, there's benefit to the AREDS formulation. If we expand that to include any geographic atrophy, maybe not such a benefit, but I don't think this should say to us, let's exclude those ARED supplements from our regimen. And then finally, because we talked about comorbidities, diabetes is certainly quite significant. And one of my former colleagues in Birmingham has this kind of litany for his patients with diabetes. And basically, if it's white, don't eat it unless it's cauliflower. Is probably very, very useful. I know I try to minimize my intake of bread because one of the maxims that my patients with diabetes used to say is the whiter the bread, the sooner you're dead. One other thing, and this is something that my wife came up with. Bless her heart, she's the beneficiary. So she said, listen, I don't want you eating anything that comes from a vending machine, anything that you can get through a drive-through, or anything that is advertised on television. I said to her, honey, what does that leave? She said, wine and certain chocolates. So if we kind of use this as a baseline for what to avoid, maybe we're going to be a lot farther ahead in our march against geographic atrophy and advanced age-related macular degeneration in general. So looking at my clock here, it just turned 12:56. So if we can use an Olympic analogy, I think we've stuck the landing, and we have a few minutes for question and answer.
All right, so we have the Q&A box. So I have them pulled up here and we'll remove them as we go. I can ask you if you'd like, or you can read them yourself, your choice.
First, there are 11 questions. The first one is absolutely fabulous here. What are the advantages and disadvantages of blood thinner therapy for someone with age-related macular degeneration? This is a topic that has been arm wrestled with in the literature over decades, and no one can come to a conclusion. Some studies show that it's beneficial. Some studies show that it has no effect. Some studies show that it is a problem. So my take is, if your cardiologist wants you on a blood thinner, it's probably very important for you to do that for your overall health, and any visual consequences, because it's indeterminate, are probably secondary. Okay, and then same questioner. I've heard and seen that cataract surgery could make AMD glaucoma worse. How true is that? Well, Sue, I will tell you this. If I had macular degeneration, if I had glaucoma and I had cataracts, I would not hesitate, if I were in the early stages of AMD, to proceed with the cataract surgery, because it's going to improve my visual performance. And the way cataract surgery has evolved today, it's probably going to have very, very little impact on your age-related macular degeneration. And this is, like I said, a topic that's been debated in the literature. We used to have residency conferences on this. Would you recommend cataract surgery for a patient with AMD? And it's going to be a shared decision among the cataract surgeon, the retina specialist, and the patient. But like I said, if it were my eye, I would certainly have no hesitation if I got a green light from the surgeons involved. And then in the study, solely among patients who did not have vision challenges until the development of age-related macular degeneration, as a person who lost sight well past 20/40 stage at age 7, not having any great vision, I believe the results would shift dramatically. And that's part of the problem with large studies. The age-related eye disease study looked at thousands of patients, and they look at a statistical outcome and whether it's a benefit to take the supplements, for example, or not. But that may not necessarily apply to any particular patient in the study. So excluded from AREDS were patients who had coexisting conditions. So those results may not be applicable to any particular individual patient. Can you have GA in one eye and wet in the other? And the answer is yes, but the follow-up question is, do they use the same injectables? And the answer is no. There are two different pathways. The injectables for wet age-related macular degeneration target a different pathway in the evolution of the disease to try and reestablish the integrity of circulation, whereas the injections for dry or geographic AMD are looking to interrupt the process that disrupts the pigment epithelium, which does not have a direct vascular supply. So I hope that wasn't too much detail there. Is the drusen that the doctor talks about related to cholesterol? Would cholesterol medications help this? Again, this is something that seems to, in the literature, patients on statins do show some benefit for that. So that certainly is something, if you're taking a statin like I happen to be doing over the last couple of years, is probably not going to be detrimental and may in fact be beneficial. I've heard there is a new treatment coming out for GA. Are they any better than the first treatments that are out now? So the first treatments were the injectables, and those showed promise in terms of stabilizing the disorder or slowing the progression. The light therapy now really shows promise in the small study from Sweden, and hopefully is going to be FDA cleared by the end of the year to actually stop the progression and maybe even reverse it, as the next question asked. Can geographic atrophy affect your peripheral vision? Typically, this is something that's within the very center of the vision, and there are other things that would affect peripheral vision. Are there glasses or vision aids that can help? Yes, and I'm going to elaborate on that because there are visual aids in terms of enhancing contrast, improving magnification, et cetera, that are on the kind of the low vision side. But there are also spectacle lenses now that use artificial intelligence in order to improve visualization. And those are going to be more widely available in the next probably year or maybe two, and something that might be beneficial to those who have geographic atrophy. Okay, light therapy, can that reverse it? The hope is yes. But what we saw with the early injectables, the anti-VEGF agents, if you're familiar with that term for neovascular AMD, those improved vision, and that was an absolute breakthrough. And it seems that there may be improvement here to a lesser extent, but we don't know how long that lasts yet because we don't have 5-year data. We have 1-year data. Are there medications, therapies effective for myopic macular degeneration? That's something that's pretty close to home here, because I have a neighbor who had lost vision at an early age in his right eye, and now has myopic macular degeneration in his fellow eye. And he has now had his third injection for the neovascular form, the same application as neovascular age-related macular degeneration. His vision has improved about 2 lines, and I know that because he just shared his medical records with me. They were in my mailbox yesterday, and his vision has now improved from about 20/40 to 20/25. So yes, there is utility for the neovascular form of myopic degeneration, because it's a similar pathologic process to age-related macular degeneration.
All righty, Dr. Sims, I think that will do it for today. We want to thank you so much for coming on and joining us and giving us this wonderful information and answering all the questions. And we want to say thank you to everyone who was able to attend and to provide some of those great questions. We hope you got a lot out of this, and don't forget to check our website for more upcoming programs, as well as we are still doing live programs. So you may have a program coming to your local area. So go ahead and check our website at macularhope.org. and you can find those programs and see if you can come. We would look forward to seeing you there. Otherwise, we will see you on the next virtual. Have a wonderful day.